Hi everyone, and welcome back to Need to Connect. This is video 3 of the 12-week video series, basically an introduction to neuroplastic pain in the neuroplastic world. And I wanted to just share these kind of conversational, laid-back videos with people who are just curious about learning that your chronic symptoms actually can be resolvable by using the mind and the body together. And we're doing this all through emerging neuroscience, evidence-based treatments, and we'll go through this process again through these 12 video series. Today's topic is more about why isn't my imaging, x-rays, MRIs explaining my pain? And we'll dive into the research, the emerging research over the last 10 to 30 years on what does imaging really mean? And what is it truly showing us? Because what they've done in the last 10 to 30 years is they've done imaging on pain-free people. And I think the results are going to be pretty astounding, at least they were for me, once I heard them about 15 years into my career, and realizing that all the x-rays that I've seen and the MRIs I've seen really didn't, again, explain what people experience. So we're going to kind of just hop right into the research here. So I have my little cheat sheet again. And again, this is all about, it's not simply the structure. It's more about the symptom of your nervous system being stuck in the danger alarm, fight, flight, freeze, fawn mode. Because when pain becomes chronic and you've been giving your tissue the amount of healing time, like 3 months, if pain is lasting longer than that, there's a really strong possibility that it's neuroplastic. Again, that kind of 80 to 90% of chronic pain being neuroplastic. And when we think about, again, the factors that affect it, we've already talked about this in the previous sections, but is again stress, unresolved trauma, suppression of emotions, negative core beliefs, but also just really seeing that the structure in itself doesn't even have to be damaged. The pain can kind of come out of nowhere, but basically pain is produced based on the perception of if the brain feels like it's under threat or it's in danger. It's not a direct measurement of how much tissue damage you have. That's what Western medicine has basically taught us, and it's just not true. That pain is the output of the brain if it senses threat or danger. So that's why things like imaging affect whether or not your brain feels safe and if you feel like you need to protect it. So when we think about x-rays for the 2 studies I have here are Bedson in 2008, and then this is for the knee, and then for ankles in 2023, Klopprog, I believe is their name. That was the ankle study with 231 patients. And both of these studies basically just said, hey, if you have osteoarthritis, we cannot predict the amount of pain or disability that you're going to be in just based on your x-rays. So again, as I said in the last session, I believe is you can have someone with no to mild arthritis and they can have severe pain, and then you can have someone with moderate to severe arthritis and they can have no pain. There's just no real strong correlation of the wear and tear and how severe it is in determining someone's amount of pain or disability. Now, if we want to go straight to another knee study, this one was a smaller study. It was 28 knees, so 14 different people. And in this study with imaging in 2008, 50 to 54% of the people had cartilage or meniscal abnormalities. And these people were actually pain-free people. They had these cartilage and meniscal abnormalities. Not only were they pain-free, they were actually NBA players with the average age of 26. So again, looking at these MRIs and x-rays is understanding that they're normal abnormalities, or in the neuroplastic world also we like to call them incidental findings. Because we're now seeing that, oh my gosh, you see these a lot on pain-free people. If we hop right into the bilateral shoulder MRI, so this is where they would take people and give them MRIs on both shoulders. In one study, again, Barreto in 2019, and if you know anything about medicine, it does take 17 years for medicine to start actually using the stuff that research is supporting works. So in 2000, again, let's see, 19, it was 123 MRIs, bilateral shoulders, and in the painful group, 44% of people had labral tears. You go, okay, yeah, Anita, yeah, see, it's a tear. But then if you go to the non-painful side, 41% of those people also had labral tears. And then another one, there's a lot of different diagnoses they had, but just ones I picked out here. Subacromial bursitis is something I'll see in clinic. And 54% of patients with painful shoulders had subacromial bursitis on their imaging. But in the non-painful group, 56% of them had it. So even a higher number in the non-painful group. And the even bigger study that was done in 2026 for rotator cuff abnormalities is they had 602 adults from the ages of 41 to 76 get MRIs. And how many patients do you think had at least one rotator cuff abnormality? Just guess. The answer is 99% of pain-free people had an abnormality on their MRI. Even including partial tears, 62% of those patients had them, and full tears in 11% of pain-free patients. And when we looked at the 492 pain-free shoulders, 96% of them again had rotator cuff abnormalities, and in the 110 painful shoulders, 98% of them had abnormalities. 96, 98%, 6, 7. Anyways, just kidding. The 96, 98, like, right, not really a significant clinical difference there. To me, that study was just like, it definitely has to blow your mind. For low back pain, the big one that a lot of neuroplastic clinicians will refer to is a Bulging study in 2015. And it was a systematic review of over 3,000 patients. And what they found, and I'll just give myself an example, I'm 48 years old, is that 50, or actually I think it's, I'm going to round up to 50, and that, 50, I'm rounding up to 50 years old, 60% of people in that age group have a bulging disc with no pain. Another one is degenerative disc disease, which isn't even a disease. It's a terrible name because it scares the crap out of people. People come in all the time saying, oh, it's the degenerative disc disease, just like kind of another name for arthritis. Is 80% of people in my age group have it with no pain. So think about, you go to the doctor, and the doctor's like, oh, on your imaging you have degenerative disc disease and bulging discs. And you're like, oh crap. Right? This is how MRIs can cause a nocebo effect, because now you're protecting your guard and you think you're broken. Right, so I'm here to tell you, like, MRIs for low back pain, if we look at this other study where it was people with really intense, serious low back pain, and they followed them, the subjects, 200 subjects over 5 years. And what they found in those 200 subjects was that the ones with, again, really severe pain, only 4% of them had something significant on MRI that would explain their severe symptoms. I would, again, clinically say by far the most severe pain that I've seen, especially backs, are neuroplastic. Like, they can't get out of bed, not sure what happened, wake up in the morning. The one guy I keep remembering is a guy that woke up again one morning, couldn't get out of bed. That lasted for like 3 weeks. And then when I talked to him about it, his friend had committed suicide like a couple days before that happened, and he was actually trying to help his friend get sober. So again, it's understanding that pain is not a direct measure of tissue damage. Pain is the brain's output of how much threat it's under. So again, that's why life stressors, suppression of emotions, negative core beliefs, right? Having the personality traits of trying to take care of everyone else first and putting yourself last. You don't have self-compassion for yourself. All of these different layers of our emotions trigger the threat or danger response, which then we get stuck again in fight, flight, freeze, fawn mode. So really understanding that your body's pain alarm is influenced by all these other factors. The sensitivity of your pain alarm can be affected by your imaging and your x-ray. So what this means is it's actually good news in a way that if your symptoms don't really match up with the x-ray or what the image says, and that's where, a physical therapist, maybe a coach, can be more helpful, is they can, look at the image and see if it actually matches up or makes sense with what your symptoms are. Like if there's a rotator cuff tear, kind of, that's significant, it'll be in a specific area. Or again, with certain findings you'll find on spine imaging, you can look at dermatomes, myotomes. We don't need to get into that, but it's allowing you to have some hope that your nervous system is the thing that's fueling your pain, because it's rewirable. Because that's the whole concept of neuroplasticity, is you can actually, as Howard Schubiner puts it, unlearn these neural pathway circuits of this chronic symptom. And you can do that through expressive writing, which again sounds really weird. We'll get into that. That's more the treatment part of it. But you're allowing yourself to feel the emotions that you've shoved down or suppressed for years or decades. Pain reprocessing therapy, EAET, emotional awareness, expressive therapy. Those are all outlets of how you help down-regulate or turn down the nervous system alarm, along with some of the other obvious things of meditation. People do some tapping things. Even just like some people say in the neuroplastic world, go get a massage, don't get any kind of external treatment, which sometimes I agree with, sometimes I don't. As long as you are on the boat that your symptoms are neuroplastic, it's okay to get a massage, as long as you're not thinking that it's fixing you, but it just feels good to get a massage. So if you feel like this video resonates with you and you're kind of curious whether or not your symptoms are neuroplastic, that's what we're going to cover the next session, is looking at the way that neuroplastic symptoms act and seeing if you can kind of almost like a diagnosis on your own to see if your symptoms in themselves would respond well to the neuroplastic treatment. And that way I'll be able to help guide you, and you can stop avoiding the things that you love and get you back to movement, because that's another thing that actually predicts pain better than imaging is we call it the fear-avoidance model, but is the more that you fear, or the anticipation, the expectation of the symptom or the pain, that actually is a really good predictor for how much pain you're going to be in. So anyways, don't want to get too long. So if you enjoy this, like, follow, and share. Reach out to me if you feel like you need some guidance, or you're just kind of curious if your symptoms are neuroplastic. And we're just going to continue again on this journey of this 12-week series. And I appreciate you guys, and we'll see you next with Need to Connect. Bye-bye.